Just in terms of disclaimer, no financial or commercial interest in anything that I'm discussing today. And also just a reminder to you guys, we're going to take questions at the end. So welcome. I want to extend a huge appreciation to Julie Carter, Lisa Mann, Dr. Jay Nutt, and all of the colleagues at Oregon Health Sciences University Parkinson Center. It has been an amazing year for me in terms of collaboration, and also a privilege to be able to serve their Parkinson's community. I'll tell you that in my background, I have worked with a whole range of people with chronic disease, acute illness, and I love what I do in terms of health psychology, behavioral medicine. And I've worked in a Parkinson's center back at Spaulding Rehabilitation Hospital in Massachusetts. And I come to this with a particular passion. I'll tell you why. From a personal note, I have a young brother, actually he's not that young, but he's younger than me, who was diagnosed about a decade ago with young onset Parkinson's. And I also have an uncle who, growing up back in Cape Cod, he and I sailed the waters of New England all the way from Cape Cod all the way up to Canada together. He passed away a year ago with end-stage Parkinson's with dementia. And so the personal connection is a real motivating force, and it gives me great interest. But I must tell you, as mental health practitioners across the board, and I love the people that I've worked with throughout kind of all medical conditions, but the Parkinson's community offers something really remarkable. It's a group of people who have a tremendous amount of resilience. They're eager, they want to learn about how they can help themselves and manage their condition. And it seems to me that they come from a whole range of life experience, but many very high-functioning, successful people get hit with this diagnosis and then need our help to help navigate these challenges. So today, I'm going to be talking about PD depression, anxiety, psychosis. I want to review with you folks about the clinical interview process and assessment. And then I want to go into some detail about therapeutic approaches and models working with folks with Parkinson's disease. There are major psychological issues that affect people with Parkinson's disease and their family members: depression, anxiety, psychosis, but a whole lot other significant emotional challenges. We definitely need more folks who are specialized in mental health working with this population. People who have background in medical and health psychology, social work, and psychiatry. We absolutely need a lot more education and training for mental health professionals, and there's a great need for applied clinical research. This particular discussion today is going to be really clinically focused. There is information in your packet with a lot of references looking at the literature review and studies, so you can refer to those. Previously in this program, you heard about the National Parkinson's Foundation Outcomes Project, the Quality Improvement Initiative. This is an amazing study that's ongoing, and it came out with its first publication last year, looking at over 5,500 patients from 20 PD centers of excellence across the country, and including 4 countries altogether. As you had learned, one of the most profound outcomes from this quality of life study has found that depression and other mood challenges are the #1 thing that negatively impacts people's quality of life. It's an important finding, and the NPF has recommended annual depression screens so that people can be identified and referred to appropriate referral sources. So what are these mood issues and challenges that people are faced with? It's been said that up to almost 50% of Parkinson's patients experience some level of depression. Anxiety a little bit less with 40%, and the combination of the two, the mix of depression, anxiety, is about 20% in the Parkinson's population. In terms of cause and etiology, it's really thought to be a combination of more situational factors in addition to endogenous or sort of neurobiological factors that are creating these mood changes. There's talk, we know about dopamine being reduced in Parkinson's patients, but there's a lot of look at other neurotransmitters such as serotonin, norepinephrine, and others that seem to be related to some of these mood changes. And you also have heard that these mood issues, depression, anxiety, are often very early signs that Parkinson's disease is emerging. So I think the take home with this is that these mood changes are an inherent part of the disease process, and we need to remember that. So mood changes, depression, anxiety are significantly underdiagnosed, and there's reasons for that. We know in our professions that there's the mental health stigma, so patients and families are not necessarily coming to the table, coming to their doctors and other professionals, talking about these difficulties. It's also underdiagnosed because specialty physicians and primary care docs do not necessarily have the mental health focus or training and education to be able to focus in on these issues. In addition to very busy healthcare practices, it's not always something that gets addressed. So let's talk about depression and look at some of the signs and symptoms and how this is sometimes very hard to tease out with Parkinson's disease. There's a significant overlap between Parkinson's disease symptoms and depression itself. If you look, you know that people who are having depression have difficulties with decreased interest in pleasure, loss of energy. We know that flat, blunted affect that people have with depression. But it's also important to note that apart from depression, Parkinson's patients have these non-motor symptoms of apathy, that sort of lack of initiation, and significant issues with fatigue and low energy, in addition to what's called sort of the Parkinson's mask. It's in essence, a freezing of the facial muscles that people have that very sort of blunted expression. So it's important to recognize. And I think it's also, you should know that it's easy to misdiagnose a Parkinson's patient with depression because of some of these non-motor symptoms that come up aside from depression. Other symptoms. Mental health folks know about psychomotor agitation and retardation, sleep and cognitive issues, very common in the general population with depression. But also with Parkinson's disease, we have restlessness and bradykinesia. Bradykinesia is the slowing of motor movement, and so it has that overlap with depression. Sleep disturbances are very common, both in Parkinson's and in depression, as well as you've just learned, there are significant cognitive issues that can be present with Parkinson's disease. So teasing this out can be quite challenging. When I do an assessment with folks that come to me, I really put a lot of emphasis on things that have to do really with the experience of dysphoric mood and depression, and getting that sense not only from the patient but from family members also. You want to really take a close look on appetite and weight changes, the feelings of worthlessness and guilt, meaninglessness, those kinds of things. And in some cases, suicidality, recurrent thoughts of death. So focusing on these are primary, in addition to seeing what other kinds of symptoms that tend to overlap between depression and Parkinson's. it's important to note, and especially with folks who have cognitive issues, that they may have a decreased insight into their own emotional experience. And in that case, it's really important to touch base with family in terms of getting their sense of where their mood is. Generally speaking, the experience of depression tends to be more in the mild to moderate range and not as significant and severe that you might see in the general population of clinical or major depression. And along with that, suicidal intent or gestures is not something that you will experience in your counseling or practices that much. It's just not as common as is in the general population. I would say, having worked with people with a whole range of medical diseases and challenges, that people, when they become quite advanced in their disease process, do have that experience of sort of this passive wishing that it would all be over, wishing to die, but that's not the same as sort of a serious intent or having serious suicidality. I think that's important. So I want to switch a little bit to anxiety, Parkinson's anxiety. And I'm going to talk about situational. I also would mention along with that social anxiety, generalized anxiety, panic attacks and anxiety attacks, and then this phenomenon called internal tremor, which we'll discuss in a moment. So in terms of the situational anxieties and the social anxiety, one of the big issues is that people have this sense of deep embarrassment about their situation in social settings. It can be quite mortifying to be in a situation, as you had seen before, getting into a freezing episode or having a dyskinesia, which is, it's a very upsetting thing in a social situation and very embarrassing. So people have significant fears around looking, quite impaired in social situations. People fear falls. They definitely fear further injury because it's very difficult to recuperate, with another injury. People fear mental incapacity. A huge issue in my sessions with people is that tremendous concern that they're going to be dependent on others, and especially their loved ones, and they do not want to have that dependency on others. So that's a huge situational fear, anxiety. And then tremendous fear around what's the financial implications of this process, especially if it's a young onset people in particular, if there's a long and difficult course. What's that going to mean to their financial future? General anxiety, within the group of Parkinson's patients with anxiety issues, generalized anxiety tends to be about 10% of that group. And as you know, as mental health professionals, it's that sort of free-floating apprehension that sort of persists. Motorically, it's the feeling of tension, restlessness, headache, and other things. And then from a physiological standpoint, there's the autonomic nervous system is sort of in overdrive. The sympathetic nervous system kicks in, people get short of breath, they have increased blood pressure, heart rate, sweating, dizziness, all kinds of physiological symptoms that go with that sort of general anxiety scenario. The generalized anxiety tends to be something that persists and can last from weeks to even months. So it's a big issue for a portion of the Parkinson's folks. Anxiety, panic disorder. As you know, it's a kind of recurrent attack of severe anxiety. It appears not to be due to particular triggers or situations. And so there's no real correlation with some event that happens and then people going into the panic attack. And then sort of, in essence, that it's quite unpredictable. The physical signs, palpitations, chest pain, choking, dizziness, that feeling of unreality are part and parcel of that panic attack that many of you are familiar with working. And this is true with Parkinson's folks. There's also that secondary experience that they're dying, they're losing control, or they're just losing their mind. So that's the panic disorder. That tends to be about 30% of the Parkinson's population that have anxiety. Now, internal tremor is a new phenomenon to me in many ways, and doing a lot more looking into this. But it's this experience that PD folks talk about, where there's this internal sensation of tremoring inside the body, like the chest is shaking, or the abdomen, or the legs, the arms. It's this sort of internal tremor, if you will, that does not seem to be related to the level of their function. It does not seem to be related to an observable motor sign, such as a tremor, or a late stage or anything like that. So across the board, people, I've heard somewhere in the range of 40% of folks have this sort of internal tremor phenomenon. And it's thought to be primarily associated with anxiety because it does not seem to respond to your typical medications that you would treat with for anxiety. I wanted to go over some of the mental changes that people experience with Parkinson's disease, kind of the whole spectrum. The mild to moderate cognitive changes, the Parkinson's dementia, and the PD psychosis. The cognitive impairment, they range, as I've said, from mild to quite severe. The impairment does seem to increase with age and with more late-stage Parkinson's. And as Julie Carter had mentioned in her presentation, it seems to be very, very strongly associated with decreased quality of life, not only for the patient, but for the family. When you think about cognitive impairment, a lot of people sort of jump to well, there's attention, concentration, and memory difficulties. When in fact, in my experience, with some of the mild to moderate changes that people are undergoing, often it is some of that executive level functioning, that sort of the frontal cortex signs of can't juggle things. Problem solving is more difficult. Multitasking is more difficult. Organization. So I have patients who are finding, even if their Parkinson's is sort of middle stage, that they're having trouble scheduling their appointments with doctors or doing the checkbook or various things like that. Visual spatial issues are a prominent issue for many people with cognitive changes. I had one gentleman who I adored, who actually has had Parkinson's for about 25 years. He had deep brain stimulation, and he had this difficulty with sort of visual proprioception, the inability to know where your body is in space. So he came into my waiting room, and I had another patient in my office, and all of a sudden I hear this enormous crash. And it was the side of the brick wall of the building. It's an old Portland building made of brick, and I felt this vibration, and I rushed out, and there's this gentleman, Parkinson's patient, who was just reaching back to get the arm of the chair, and he missed it by a foot and ended up falling into the brick wall. He had DBS. He said he was okay. I wasn't going to mess around. He went off to OHSU emergency to make sure none of his wires were disconnected. But these are the kinds of visual spatial issues that people can have trouble with. The mental processing, sort of the slow, delayed processing, is a big issue for many people. I've often heard it referred to as this sort of brain fog, the slowing of mentation, especially when medications are off. My own brother talks about this when his medications are wearing off. And again, attention, concentration, and memory are issues with some of these mild to moderate changes, but not necessarily the prominent ones. The more severe cognitive issues, we talk about Parkinson's PD dementia. And roughly 15% or more, these symptoms include more significant disorientation, confusion, and I'll say there's a lot of variability, fluctuation in the cognitive presentation, more significant memory loss, decrease in social awareness and safety awareness are big issues for folks who have the Parkinson's dementia, and you can get into more issues of behavioral changes, personality changes, and impulsivity. Also often associated with the Parkinson's dementia is psychosis, which we'll get to in just a moment. The Parkinson's dementia, it is much more common with advanced Parkinson's disease. Very briefly, it differs quite a bit from Alzheimer's disease, and something that Julie had mentioned before in terms of Lewy body disease. Alzheimer's disease has a more profound orientation, memory, cognitive impairment, and virtually very little or no motor difficulty. Lewy body dementia is still something that I'm digging deep and learning about, but it appears that the cognitive impairment is much more profound and begins in the early part of the diagnosis. They can have a significant overlap with the Parkinson's motor difficulties, but it's more profound, and it's a much more severe disabling kind of condition. Oftentimes with Lewy body dementia also are some significant psychiatric, behavioral kinds of personality issues. Hallucinations. Now, those of us in mental health, when we think of hallucinations, we think about issues of schizophrenia and other psychotic disorders. But I think it's important to understand that the phenomenon of hallucination is fairly common with Parkinson's patients. It's mostly visual hallucinations. You can have auditory, tactile, olfactory kinds of symptoms, but typically visual. And the symptoms tend to be benign, meaning that the patients don't seem to be bothered by the fact that they see little children in the room, or animals are another common one. A lot of times shadows or things moving in the periphery. They don't seem to be as bothered by that most of the time. What's important to know as a mental health professional working with a Parkinson's patient is that these visual hallucinations are likely due to medication, a side effect of some of the Parkinson's medications. And there's this great balance between trying to treat the patient's motor issues to improve the tremor, the slowness, those kinds of things, and keeping these visual hallucinations at bay. It's a very challenging kind of thing. And in many cases, these hallucinations are separate from a dementia. People can be cognitively intact and having these difficulties due to the medications. So when we get to the issues of delusion and paranoia, it's a much smaller percent, but again tends to come more in later advanced stages of Parkinson's, often associated with Parkinson's dementia. It's very rare that you will have a person who's sharp, intellectually on target, cognitively intact, and be having delusions. There is a very small subset, and I've had a few cases in my own practice where you can have someone who is cognitively intact and be having a delusion and paranoia around particular issues, particularly around pathological jealousy. And this is often referred to in the literature of the Othello syndrome. So, as you all know, distorted reality, misperceptions, delusions, that the lack of trust and suspicion as the paranoia. And I think, as was mentioned before, the common kinds of delusions, paranoia that people struggle with are infidelity. So they're not only running off with the neighbor or some other person, but they're also fearful at times and distrusting that they're taking all their money with them too. So there's the financial fear and paranoia. I've had a number of people who also worry about intrusion, property intrusion, neighbors trying to break in, that kind of thing. I had another gentleman who felt that he was convinced that the camera in his MacBook was watching him, while he was in his home study. And also that the computers and any other technology were sending out some negative energy vibes. And so these are the kinds of things. Not that common, but something to be aware of. So let me segue a little bit with you guys and talk more about the interview and assessment process. And this is rudimentary for all of you, but I think it's important just to say we need good background information, both in terms of how your own facility or practice gathers information, your own questionnaires. I rely heavily on records from specialty doctors, history and physicals. And I want to talk about the diagnostic interview process and a little bit about screening and self-report measures. Typically, I do an evaluation in one session. However, if I'm gathering more information or it's a particularly complex kind of issue, that sort of complete evaluation may take 2 to 3 sessions. Here's an outline. You guys know this, you were trained in it, but I want to go through it and then pinpoint some things particular to Parkinson's disease. So reason for referral, why are they coming to you? History of present illness, what's been going on the last few months that is giving them significant concern. This was mentioned a couple times earlier, but the past medical history is crucial. I have worked in settings, medical facilities, where people have a lot of comorbidities, other medical challenges that significantly impact their ability to manage not only that, but Parkinson's disease as well. I have people in my practice who are going through chemotherapy for cancer. I have a gentleman who's had abdominal surgery and he has Parkinson's. So the list goes on, but it is a very important thing to get a sense of how they're functioning in other areas of their sort of medical history. Background social history, personal. It's good to get sort of a pre-morbid sense of how people have functioned. So personal and family psychiatric history is important to get. I gather information on any altercations with the law, legal history. Military history is really important. Given that a lot of my population is geriatric, I deal with a lot of people who are World War II veterans and that kind of stuff. And those experiences, and a lot of vets and other folks in combat, these experiences have a profound impact on their functioning also. You want to get a good abuse history in terms of physical, emotional, sexual, and financial abuse, and of course, alcohol, substance. This is all rudimentary, I know. I will reiterate that a large part of the Parkinson's community that I see do not have significant problems and issues with premorbid concerns. It does come, that's a generalization, but it's certain we want to be very vigilant about these issues, because when you do have someone struggling with Parkinson's and they have a host of other sort of pre-existing psychiatric concerns, it makes your treatment very focused and vigilant. Just to complete the outline, mental status examination, diagnosis, summary recommendations, and a good treatment plan to give us some guidance. So going back, when you're dealing with someone with Parkinson's, you want to identify what are the current Parkinson's stressors that are going on. What are the main things that they bring to the table in your practice? I like to get a full spectrum history of what's happened in terms of the Parkinson's symptoms. So even, I always ask about when was Parkinson's diagnosed, but I always look back for some of those more subtle non-motor signs that may have pre-existed 5, even 10 years before. Things like loss of sense of smell, mood changes, other kinds of things. So you want to pay attention to that. Then get what their experience. I highly recommend that as you work with people, get a sense of their experience going through the diagnosis process, because this can have a profound impact in people's coping ability, in my opinion. and that is that people can have a whole range of both positive and negative experiences about how they came to the diagnosis and how they were supported and educated through that process. So pay attention to that. Of course, I like to get a sense of what are the primary motor issues because it significantly impacts their quality of life. The whole range of umpteen non-motor symptoms that you guys have learned about, it's important to get a sense of that, particularly for us, issues of apathy, issues of communication, expressive language difficulties, sleep difficulties, micrographia, handwriting difficulties. All these things impact people significantly. You want to get a good sense of non-motor symptoms. And then, of course, as mental health professionals, we want to zero in on the mood and behavioral kinds of issues. In addition, I like to get a history from the patient and the family member about the cognitive changes that they are aware of that are impacting their function. And, you know, this isn't always focused in on a typical mental health interview, but you really need to spend some time asking specifically issues of hallucinations, delusions, and that kind of stuff, because people don't normally just volunteer that initially. So you got to focus in on that. One incredibly important piece is you need to also take time to focus on the family and what is going on with the partner and other family members. You need to focus in on what's their health, how are they impacted, what's their stress level, financial impact on the whole family, work, retirement issues. I've had the pleasure of working with a lot of young onset Parkinson's folks in this community, and there are tremendous issues about work and early retirement and how that can be traumatic for folks. Mental status examination, I'm going to go through just really briefly. You know this. You know, when you first meet people, it's all about nonverbal communication, eye contact. Get a sense of how they're doing. You get to observe how they come into your office in terms of their motoric functioning. You need a good assessment of orientation, attention, concentration. Pay attention to expressive difficulties. A lot of Parkinson's folks with the cognitive issues can have naming difficulties. Visual spatial, look at the spectrum of memory problems. Again, executive functioning, focus on issues of awareness, insight, judgment, you know, similarities, those kinds of things. And how are they doing with multitasking, problem solving, and the like. And then in your session, while they're there, get a sense of their mood and their affect. And I always want to focus in on suicidality. Even though it's not that common in a Parkinson's focused practice, it is an important issue, and you want to be aware of anything going on in that domain. So I want to talk ever so briefly about some screening measures that you can use to augment your clinical interview. I tend to use the CESD, it's the Center for Epidemiologic Studies Depression Scale. And it's a very nice measure, and the gold standard for a lot of mental health folks is the Beck Depression Scale. Again, remember the issues with depression. As you're scoring these, you may want to look closely at some of the items, because if you have a preponderance of issues like low energy, flat affect, no cognitive trouble, and that kind of stuff, without some more significant actual depressive experience, you could easily, think that the person is more depressed than they are. So you want to take a close look at that. The SCL 90, the Symptom Checklist 90, has a nice subscale. I think it's 10 items that looks at anxiety. It was mentioned before, but the Parkinson's Disease Questionnaire is very valuable. And in particular for mental health folks, there's some domains in that scale that speak to our kind of work, having to do with issues of emotional well-being, stigma, social support, cognition, and communication. So it's a very valuable tool to take a look at. It's already been mentioned in this educational program, but the MCSI, the Multidimensional Caregiver Strain Index, is very helpful in terms of identifying the stress issues that partners have. And then I use, for the mental status issue, I typically use what's called the MoCA, which is the Montreal Cognitive Assessment. For those of you who've used the mini mental status examination, my read on it is that it is not as reliable, and it doesn't have as good results in terms of working with Parkinson's folks. So I really like using the MoCA. I personally am not a neuropsychologist. I specialize in behavioral medicine and health psychology, but I utilize neuropsychology quite a bit. And particularly for those when you have complex issues of cognition and mood, when you have younger people who are dealing with work-related or even academic issues, you really might want to refer out for a neuropsychological evaluation. Other legal competency issues, neuropsychological evaluations can be helpful with that. And also, I don't have it up here, but a lot of comprehensive evaluation prior to undergoing deep brain stimulation involves neuropsychological testing. And as someone had mentioned earlier, it is because that it is felt that folks who have some pre-existing cognitive issues and go through deep brain stimulation, those cognitive issues may be significantly exacerbated. So, therapeutic approaches for Parkinson's. I want to talk about some of the themes that come up in your practice, some of the models of counseling and psychotherapy, and a touch upon a little bit about multidisciplinary teamwork. So this is sort of the grist for the mill in your practices. When you're meeting with patients with Parkinson's and their family members, these are the key things that are going to come to the table. Grief, loss, and the sort of variable process of acceptance around these issues. Significant adjustment issues throughout the course of their disease dealing with the loss of independence and function. Issues typically, is work a factor, and do they have to retire early? Do they lose their driver's license? These kinds of issues are really profound for people, and people need a lot of support around the adjustment. Obviously, depression, anxiety, you're going to focus a lot on, but also anger, guilt, a whole range of emotions, including what was mentioned earlier, this issue of confidence. It's interesting. I've had so many people who've had incredibly successful, effective work and professional lives, and they go through many of these motor, non-motor challenges with Parkinson's disease, and it literally shakes their confidence. And that's a big issue that comes up in your counseling sessions. Not brought to the table that much, but sexuality and intimacy issues are paramount. The effect of Parkinson's disease itself can impact sexual performance and function. The medications that they are treated with can affect their intimacy and their sexual function. And so you have to sort of tap into this. People want to talk about this, but they're reticent to do so. And it's not often talked about in your primary care or specialty physician offices. And then Dr. Mack's going to speak about this in more detail, but this issue of impulse control problem. And again, many people premorbidly have never had impulsivity issues, but there are significant side effects of certain medications, such as dopamine agonists, which people can get into these issues of impulsivity, hypersexuality, significant impact in financial, gambling, along with a lot of other things that we'll talk about. Other issues in the therapy session: coping with cognitive impairment, helping families especially manage behavioral or psychosis issues, educating them about the visual hallucinations or some of the delusions. You have to have a little bit of a couples approach, because there are many issues of interpersonal strain when you're dealing with the patient and their loved one. So communication and relationship issues are important. I will often meet separately with the Parkinson's patient's permission to provide support and education to the care partner themselves, because they have significant issues of stress and depression themselves. And then other issues are going to come up in your counseling session: financial, family, just life stuff, I've been helping a couple. The gentleman has sort of middle stage Parkinson's. His wife is working, and they have a son who has severe alcohol and substance issues and is living in the house. So you're dealing with sort of the nuts and bolts of these kinds of things. Also, I have found, at least in my career, working with people with a whole range of medical conditions, that part of your therapeutic discussion often involves relationships with their healthcare providers and helping them navigate those relationships, which sometimes are wonderful and sometimes can be quite challenging. So just to give you a sense of what is done in the psychotherapy world, individual counseling, as I mentioned, family, both with and without the patient, group programs, which I've been involved in. There's a lot of opportunity here, I would say, in terms of utilizing psychoeducational approaches to really help people. People do very well, and it's a meaningful process to go through group therapy. And again, in your practice, you can work with folks from the very early diagnosis through end stage palliative care. Back at Spaulding Rehab, we have an inpatient service where people come in with Parkinson's, and I've been with people right to the end. So very briefly, I want to talk about models that seem to be most appropriate for work with Parkinson's folks and families. I'm going to talk about humanistic, it's the foundation, psychoeducation, motivational interviewing, and cognitive behavioral therapies. A subset of those of particular interest of mine are mind-body medicine and positive psychology. But the idea here is that you have to be flexible, you have to be somewhat eclectic, and it depends on what kinds of issues are presented to you based on what kind of tools and techniques and models you might use. So this is just, foundation. We all know this, we all have had the training, but you have to have a very unique, deep connection with the person you're working with, and it's based on trust, authenticity, positive self-regard, a la Carl Rogers, and it has to be centered on the patient and the family member. Psychoeducation, I can't emphasize this enough, but this is such an important process of your therapy with the Parkinson's community. It is promoting an overall understanding of Parkinson's disease and what are the specific psychological issues that people face, and then helping them develop and explore different strategies that can help them move towards improved quality of life. Motivational interviewing I've found to be very helpful, and in particular with issues that have to do with looking at behavioral change. So for those of you who may not know, it's sort of developing an awareness between the discrepancy of what your values are and what your actual behavior is, and helping people with that process of motivation and readiness for change, and then helping them plan and organize strategies to facilitate success. That's the work of Bill Miller and others. Very helpful for me in terms of folks dealing with adherence to exercise programs. We know that fatigue and loss of energy is huge, and it's sort of the paradox, because we know that exercise with Parkinson's is so important, so it's helping people, and the MI approaches can be very helpful. But also other things like nutrition, but even relationship, making changes in their communication style. You can use this. Cognitive behavioral therapy. So CBT, right? It focuses on changing the mindset, the maladaptive thinking, to affect both emotion, mood, and also action, behavior. And there's such a wide degree of CBT approaches, including exposure therapy for anxiety issues, cognitive restructuring, relaxation meditation, acceptance commitment therapy, many different approaches. Lots of people have good training in CBT, and it is more directive approach, and I often use the homework assignments to help carry over some of the things that we're learning in our sessions. Mind-body medicine, it's a subset really of CBT, but it's focused in sort of medical centers. There's been a lot of research that's looked at other medical conditions. I listed some of them here, and they've shown to be very helpful in terms of quality of life and outcomes. Spinal cord, chronic pain, multiple sclerosis, just to name a few. In mind-body medicine approaches, there tends to be a strong emphasis on stress reduction, cognitive restructuring, and lifestyle change. I have trained and had a lot of benefit from working with Herbert Benson out of Harvard University, who's sort of the founder of the relaxation response. He's a cardiologist who's done a lot in the field to work on this issue of improving people's function through meditation, stress reduction. And then many of you are familiar with Jon Kabat-Zinn and his mindfulness-based stress reduction program. Very appropriate usage for Parkinson's community. Positive psychology. For those of you who know, Martin Seligman was sort of the founder of this back in the mid to late 90s. He was the APA president, American Psychological Association president, and did a lot to bring both research money and focus on some of these positive psychology measures, which initially looked at sort of general population evidence-based studies where they were looking at what qualities, what character strengths seem to make people quite resilient and have positive outcomes. But it's interesting research, and I think a lot of applicability to the Parkinson's community. Topics like optimism, resilience, gratitude, spirituality, and those kinds of things. So the bottom line is we need a flexible approach. If you're dealing with depression and anxiety, you want to consider consulting with your primary, your Parkinson's specialist, your psychiatrist, in addition to your own tools that may focus more on cognitive behavioral types of approaches. For grieving and loss, it's very humanistic, sort of basic counseling model, lifestyle, motivational interviewing. It also depends largely on where the person is cognitively. And I'm a proponent that people can have some moderate level cognition and still benefit from your interaction and some of the repetition and these kinds of interventions. It's when you get to the more severe and extreme dementia, you really may be focusing a lot of your attention more on the care partner or the family. I want to talk a little bit about the research. Very briefly, the research with Parkinson's disease and psychotherapy is extremely limited. There are very few studies, limited sample sizes. Very few studies, when I've done literature reviews, have looked at used randomized controlled trials. But if the studies that do exist, CBT, cognitive behavioral therapy, sort of comes out on top, showing the best efficacy in terms of helping depression, anxiety, quality of life. CBT can be used individually and in groups. I have some references here. You can look in your packet to look these up. I wanted to highlight Roseanne Dobkin and her colleagues out at the Robert Wood Johnson Medical School, New Jersey, have done some really nice work in terms of utilizing cognitive behavioral therapy. You can take a closer look at this, but basically they use 10 weeks of individual CBT showing significant improvement in those dimensions of depression, anxiety, quality of life, and even reducing Parkinson's symptoms. She also did an interesting thing where she used a phone-based intervention, which makes me think a lot about those issues of possible telemedicine helping people. EduPark is a program that is a group program focused on Parkinson's patients and caregivers that was supported by the European Parkinson's Disease Association. 7 different countries with researchers came together and developed this curriculum that really is CBT and psychoeducation, and ran these courses, and they had some modest effect. The research showed some short-term improvement in mood, but some of the findings were mixed and didn't show that much for depression, quality of life. But I think it's a very important model to look at. We need better studies, much better studies that look at efficacy of both individual and group programs. Julie Carter and I, in the beginning of the year, ran a 10-week course that really took from EduPark and other cognitive behavioral approaches and some positive psychology and developed a program for care partners to have them learn coping strategies and to improve quality of life. We hope to continue some of those projects on both sides of the country, gathering more data over time. And again, I just mentioned I'm very fascinated in the application of video conferencing and telemedicine for some of these interventions. So it's telemental health, and it's something that's emerging greatly. Very briefly, I wanted to touch, this has been a real theme of this particular program today, but the multidisciplinary teamwork is a huge factor and that we need to keep working on. I think the patient and the family member need to be front and center in that team. And the success in patient care and also in terms of your own independent practices, it really depends on this communication piece to build strong relationships. And so you're relating with a whole range of healthcare providers, from Parkinson's neurologists, primary care physicians, physician's assistants, nurse practitioners, social workers, psychiatrists, a therapist. In my setting, I work with a lot of physical therapists, speech therapists, occupational therapists. The communication that is done with that team is critical in terms of patient care. And it's important to be a valuable member of that team and to flag those healthcare providers when significant psychological issues come to a head. Red flags on issues of visual hallucinations or paranoia, different things like that. Behavioral problems at home. It's important for the whole healthcare team to understand what might be impacting all of their different patient care. So let me just add with some final reflections. And I'm so pleased that you folks are here today, because there is such a need for the Parkinson's community to have good folks who are interested in helping them deal with these major challenges. We need more education, like we're doing today, more applied clinical research in terms of psychotherapeutic interventions. And I really believe, and I've lived it and I've breathed it, and I've been blessed by relationships within this community. People are truly lifted up when they have someone that has some specialty in helping them deal with some of these major psychological issues. I will also reiterate, I said this in the beginning, it is a profoundly rewarding experience for me to work with the Parkinson community, both here in Portland and back on the East Coast. I've worked with people from all walks of life with different medical challenges and love that work, but there is something unique and special about working with the Parkinson's community, and it has something to do with their motivation to learn, to be involved, to really tackle their problems, and to be resilient in the face of their very difficult situations. I also, just in terms of your own mental health futures, I think there is a significant move on two different levels. We talked about the demographic move of increasing the aging baby boomers, and there's going to be more and more issues that come up in terms of the mental health needs of older folks. And then also in our healthcare change, there's a great trend that's moving towards integrated healthcare that really includes mental health professionals as an important part, even on-site, an important part of that sort of treatment team. So I think there's going to be a lot of opportunities coming forward in different settings for mental health professionals. And I will conclude with that. Thank you very much for coming.